Dr. Mitchell is a board-certified physician in internal medicine and medical oncology and is clinical professor in the Department of Medicine and Medical Oncology at Sidney Kimmel Medical Center, Medical College at Thomas Jefferson University, an associate director for diversity programs and director of the Center to Eliminate Cancer Disparities for the Sidney Kimmel Cancer Center at Thomas Jefferson University. Dr. Mitchell has authored and co-authored more than 100 articles and book chapters, as well as many abstracts on cancer treatment, prevention, and cancer control. As a distinguished researcher, she has received many cancer research and principal investigator awards, including a recent Promise Grant from the Susan G. Komen Foundation. Among her many honors, Dr. Mitchell has received the Tree of Life Award, which recognizes health professionals who have made extraordinary contributions to health management in both the local and the global community. Dr. Mitchell was awarded the American Cancer Society's Cancer Control Award for her significant commitment to research, education, and diversity, and Research Award by the Council of Women Physicians of the National Medical Association. She's also the past president of the National Medical Association. I can keep on going forever talking about a wonderful personality like herself, and we were just notified that she was recently inducted to the Royal College of Physicians in London. Congratulations, Dr. Mitchell. Without further ado, it's my pleasure to present Dr. Edith Mitchell.
Thank you so much, Dr. Hussain, and thanks to the committee for inviting me to participate in the program this year with so many other distinguished researchers, clinicians, patient advocates, and others. So thank you so much for inviting me to speak. So I will speak this evening about racial and social justice in breast cancer care, planning the future with precision medicine, but assessing the past through the rearview mirror. We all should look occasionally at the rearview mirror. I have no disclosures relevant to this presentation. And what I will do is describe some information about cancer mortality rates, some historical events that impacted cancer outcomes, impact of Medicare and cancer disparities, disparities in breast cancer, and then some future direction regarding precision medicine in cancer research. So the poet James Baldwin said, "Know from whence you came. If you know whence you came, there's absolutely no limitations to where you can go." So we're all working with research, clinical utilities, screening, all of those things to increase and improve cancer treatment outcomes. But we must think about the past so that we can decide what is necessary for the future. So non-Hispanic women and breast cancer, Black females have a higher incidence of mortality from breast cancer, yet white women have higher incidence rates. So even though we've made all of these great strides in the treatment of breast cancer, Black women still have higher mortality from the disease. So we've got to work to define what is necessary to make sure that we are incorporating all of the factors that we need to in terms of treating breast cancer, diagnosing breast cancer, so that there is parity. Note that over a period of years from 1975, there has been a decrease in death rates from breast cancer, but still African American women have higher mortality rates than others. Note that from 1975 till about 2000, only data on Black and white women was collected. Now we collect information on many other racial and ethnic groups. So it's always important to look at everybody else. And what we know for this whole period, African American women have worse outcomes, higher mortality rates. And yet, Black or breast cancer survivors are the highest group of survivors in the country, except for prostate cancer in men. But in women, breast cancer has the highest number of survivors in the country. And as we look over long periods of time, note that there has been a substantial decrease in cancer death rates in the country, with overall approximately 30% lower death rates over this period of time. So we are improving, we are having better outcomes, and that 29% decline in age-adjusted cancer mortality rates over 25 years, what that means is almost 3 million Americans did not die of cancer. So it's a good thing. Now, as we have looked at the last 20 months, what we find is in minority communities, there is a disproportionate burden of cancer cases, hospitalizations, and deaths across racial and ethnic groups. And with that, we have noted a decrease in the number of screening procedures, both in breast cancer and other malignancies. And the projections from the American Cancer Society are that we, in about 2023, will see a substantial increase in the number of not only breast cancer cases, but others also. So as we look through the rearview mirror and then look ahead, we've got to plan for this predicted use of or decreased use of screening procedures, and therefore predict for what we will do about this increase in cancer cases as is predicted. So why do we talk about diversity in cancer care or diversity in healthcare? The AAMC published this a few years ago, evaluating individuals in this country who were over 18 years, and noted that 68% of the individuals in this country were Caucasian, with percentages of others. But if you looked at those under 18 years, note that the number of whites decreased substantially, and the numbers of minority groups increased significantly. So if we are to be very important and very precise in healthcare delivery, we've got to know our population, and we've got to address our diagnostic and therapeutic interventions according to the community. And we know that there is a substantial increase in minority individuals in the country. So therefore, we've got to address that. Dr. Harold Freeman provided this information indicating that when you're looking at the development of cancer, we must evaluate multiple components. That is social injustice, poverty and low economic status, as well as the culture. And all of these can affect the gene environment. So therefore, we need to be continuously evaluating what we can do about prevention and early detection, diagnosis and incidence rates, treatment, the post-treatment quality of life, and overall survival. So therefore, we've got to focus on a number of issues and make sure that we're including our research throughout this continuum. So it's not just looking at the treatment today, but we've got to project backwards and try to prevent, and forward to evaluate survivorship. So very important. So let's talk about some cancer outcomes and these historical events that influence both the incidence rates of cancer, but also therapeutic interventions. So one of those was founding of the National Medical Association. It is the oldest and largest organization representing African American physicians and health professionals in the United States. It was founded in 1895 during an era in American history when the majority of African Americans were disenfranchised and African American physicians were denied membership in most medical societies and entities. So, founding of the National Medical Association. And here we are 126 years later, and we're still talking about inequities and disenfranchisement. So one of the areas of medicine that truly made a remarkable change in healthcare in this country, and that was the study of 1910, the Flexner Report. And the Flexner Report was to change and improve medical care in this country. But what it allowed for was closing of all of the Black medical schools except Howard and Meharry. That decreased the number of practitioners in this country and therefore access to healthcare for many African Americans in this country. And this was partially responsible for the low number of African American physicians. So while all of the Black medical schools were closed except two, there was no increase in admissions to majority medical schools, not substantially, to make up the difference. So therefore, many African American students lost the opportunity to become physicians. But not only that, the Flexner Report, and these words are taken directly from it, Blacks should be trained in hygiene rather than surgery and should mainly serve as sanitarians whose purpose was protecting whites from diseases like tuberculosis. So think about that. You've had a great week and all of these great individuals participating. And think about it, if we were all relegated to just being sanitarians. So this report made a big difference in medical education in this country. Another area that was very important was the National Cancer Act of 1971. And that meant that there was establishment of the National Cancer Institute, the advisory boards, where education and training and research programs, the cooperative group programs, cancer control programs, and the surveillance epidemiology and end result, that we all use multiple components of this regularly. So 1971 Cancer Act, and now it's 2021, and that means 50 years of good cancer research in this country and dedication of the National Cancer Institute and components in that. So with that, there are some substantial people that I have to discuss. One is Dr. Jane Cook Wright. Dr. Jane Cook Wright was one of 7 original founding members of the American Society of Clinical Oncology, the only woman in the 7-person group, the only African American in that group. And ASCO has grown from 7 people to more than 40,000 individuals attending the event. Not only was Dr. Wright and her father, Dr. Wright, interested in cancer and were cancer clinicians and researchers, but they were also very interested in health policy. Her father, Dr. Wright, who is shown here with First Lady Eleanor Roosevelt in this area. Dr. Wright was also chair of the board of the NAACP for 18 years. You can see her in many different avenues here. And here the National Medical Association is giving her the Lifetime Achievement Award. So Dr. Jane Cook Wright, she is now deceased. And one of the things, I bring this up to say, one of the things that can influence cancer research and delivery of cancer care and clinical trials to the communities is by our workforce diversity. And therefore, very important that we work to increase our diversity in the cancer physician clinical force, as well as pharmacy, nursing, all of the others. Note that over a period of years, the number of African American and Hispanic physicians has not increased significantly, and we must do something about that. So the Accreditation Council of Graduate Medical Education over the last 3 years has really brought this forward with DEI, that's diversity, equity, and inclusion, to make sure that each training institution and training more people to do what we do in cancer care is really important. So we've got to work with our institutions to contextualize the issue, accept and own the issue, and then act to make sure that we are using our tools, skill, and expertise to grow the workforce, and that we're accountable with evaluation and expansion with the fact that equity matters. So we need to bring more individuals into the workforce so that we've got innovative ideas, we implement these strategies, and therefore increase the solutions in the field. So we are bringing on more of us. And this is depicted in a way to show that with inequality, you've got 2 people and they can't figure it out. And this person on this side of the tree is just totally confused. We could say equity, and let's give people some ladders and give somebody a little bit higher ladder. But look, there are no apples or fruit on this side of the tree. So equality, you still have somebody short of achievement. So what we really need to do is fix this tree. Note that it's bending. So we need to straighten this tree up so that the tree has fruit and all individuals can take part in the equity of cancer prevention, diagnosis, early treatment, and then survivorship. So we've got to fix this ourselves. And if we don't speak about it now, who else is going to speak for those coming behind us? So how about Medicare? And I was asked sometimes, why do you keep Medicare here? What does Medicare have to do with it? Well, Medicare was signed, passed by the Congress and signed on the 30th of July, 1965. And this is a picture of former President Johnson signing this bill, not in the Oval Office, but he flew to Kansas City, Missouri, and it was signed in the Truman Library. Former President Truman was the first president to address Congress and ask for an insurance plan, he said for the elderly, but it was really over 65. So there's a difference between elderly and just the age of 65, but it's the age of 65. So after signing the bill, President Johnson provided former President Truman and his wife Bess the first two Medicare cards. Well, what does that have to do with disparities? It was a major force for racial desegregation in healthcare facilities. So all of the signs saying white only and colored on another door were removed. The wards were integrated, so you didn't have a black ward and a white ward. But not only that, the hospitalization rates improved so that more Blacks had access to care, and the disparities in access to healthcare services decreased significantly, and the gap was decreased. So Medicare allowing for benefits and coverage. I mentioned the National Cancer Act of 1971, and we again have the 50-year anniversary. And what we notice that over the years, breast cancer diagnosis has increased in some years, decreased in others. And there are a lot of factors, including the prevalence of mammogram screening, the fact that hormone replacement therapy was removed from standard treatment guidelines. So a lot. And there are a lot of other contributing factors, including lifestyle, genetics, environmental exposure, and others, allowing for breast cancer to have higher mortality, advanced stage and distribution at diagnosis, lower lifetime incidence, younger age distribution, increased frequency of adverse tumor features, and higher incidence of male breast cancer. Note that there has been a improvement with percent declines, and it's identified by states. So note that the dark blue indicates the highest percent decline. So you could think about, if we want to change breast cancer incidence rates, we could all move to the dark blue states. But we've got to fix this for all over the country. Note that there have been some advances with incidence rates approaching each other in terms of white and Black, but still mortality rates have a marked gap between overall outcomes. One of the things that has been noted, that if you divide breast cancer into prognostic groups with the HR positive and HER2 negative groups, note that more whites are in this category. And yet, if you evaluate the most aggressive groups, triple negative breast cancer being twice that of whites in this country. So very important to do that. And you've heard of all of the guideline recommendations. Mammograms at age 40 are not at age 40, but somewhere 40 to 49. But think about this, for African Americans, if you delayed mammography until late 40s or 50, note that there are quite a number of individuals who would have presented with breast cancer because of delayed mammograms. So my recommendations are, we need to get the groups together, and those individuals who recommend mammograms later, we need to educate them and get that out of health policies. So we all know triple negative breast cancer and what it means. I'm going to move on. Of course, it accounts for 15 to 20% of all breast cancers, depending on the state. And we therefore need to work with this. It's most prevalent in premenopausal Black women and in some other racial and ethnic groups as well. There's been a lot of talk about neoadjuvant therapy. Do you recommend it? Do you not? How does it affect overall survival, disease progression, and distant disease recurrence? There have been a number of studies, and they do favor neoadjuvant chemotherapy for triple negative disease, especially in women less than age 50. So one of the hallmarks of this therapy is whether or not there is a pathologic CR, complete response, in other words, absence of invasive disease at the time of surgery. And that's a good prognostic indicator. But it's also important to recognize whether the primary tumor was a larger T or a smaller T, and whether there were lymph nodes present at the time of diagnosis. Because even with the PCR, this is not equal in all areas. But a pathologic CR, of course, is our outcomes target. There's also been a large amount of information. Do you use carboplatin? Do you not use carboplatin? And we know adding a platinum compound increases side effects, neutropenia, thrombocytopenia, and there can be dose reductions, dose delays, and actual missed doses. And this can therefore negatively impact ultimate outcomes. So we've got to look at the side effects of therapy and how adding on more isn't necessarily the best thing for every patient. So think about that as we add new drugs to the treatment intervention regimen. We have other drugs that have been added, and certainly we have olaparib and tilazepam been approved by the FDA in recent years for HER2 negative metastatic breast cancer, as well as germline mutations in the cancer. And what we look at is the overall effect at the cellular level, and therefore using predictors of cell survival as we use both PARP inhibitors and other drugs to regimen. We've got to look at whether the treatment is oral or IV, the frequency of visits to the clinic, the out-of-pocket cost that patients need and or meet as they explore various therapies. And now we have immunotherapy being added to the regimen. So there's more to come on research, and it's so important to make sure that our patients get into those clinical trials. And in working with the community physicians and others, our patient advocates, our community groups, so that we are bringing everybody into the regimen for treatment. And we've got not only equity, but we've got justice. Another area of research is that the breast cancer relationship to obesity. It is well recognized that Black women have the highest obesity rates in this country. But what we know in relationship to cancer is that many cancer cells have insulin growth factor receptors, and there is insulin resistance in obesity, so that therefore more insulin circulating and in tissues, and thereby may influence not only the growth of cancers, but the response to treatment. There is the NIH All of Us mission that is ongoing. It plans to collect information and tissue, plasma, urine, and other samples on over 1 million individuals. And with that, most of these individuals are well and have no evidence of disease processes. So it is a predictor. And there are some oncology studies that are being devised now. Look at some of those predictive factors and estimates of risk for not only cancer, but many other diseases. And it hopes to develop solutions to health disparities by defining the risk for certain diseases, and especially those that affect disparate community. So over 1 million people. And I advise my patients to participate in this. Is the link where you can find information. There's also the MATCH study, which is another precision medicine study where we enroll individuals based on mutations in their tumors, and we look for responses with matched therapeutic drugs, and we call it match. You match the mutation in the tumor with the therapeutic entities. The study has 39 arms, 39 different treatment regimens, and is currently ongoing and being evaluated. So how can we reach the community and get our patients into these programs? Because in many communities, there is a lack of trust, and individuals just are not coming in for clinical trials. But not only are patients not coming in, but doctors don't offer patients those clinical trials. There was a study done by patients that, and the most common factor for not participating in a trial was that the doctor didn't invite me to participate. So we've got to fix this on the community level, where we're working with communities, improving and enhancing trust. But we also have got to work with our clinicians so there is not the bias related to clinical trials and whether African Americans or other minorities will participate. And we've got to enhance the approach to genomic and clinical research to allow full benefit. We can't have a tree with no fruit on it and it bending in a direction that is away from individuals in the community. So we've got to provide that genomic and clinical research to allow full benefit of precision medicine, new drugs, new therapeutic interventions, so that all racial, ethnic, and socioeconomic populations have justice in participation. This is a plan that we set at the Kimmel Cancer Center some years ago, making sure that we had community outreach, partnerships, basic scientists, clinical science, behavioral and epidemiology, all involved and all focused on increased accrual to our clinical trials and making sure that we had the populations from our community involved and working with the community. So in summary, we've got precision medicine now, and we've got to use that and make sure there is equity and justice in precision medicine so that everybody benefits from this. We've got declining cancer death rates, especially since the National Cancer Act of 1971. We understand some things about disparities in cancer incidence and mortality rates and the impact of social determinants of health, but we've got to use all of this information to make sure that we're getting patients into the clinical trials. it's very important to remember the historical contributions to the decline in the cancer death rate, and make sure that we are looking through the rear view mirror to see where we've come, and therefore predict where we're going. We've got definitions of cancer health disparities. We've got new therapeutic research interventions that assign therapy to patients based on the genetic and genomic changes found in their tumors through genomic sequencing and other tests. We've got the All of Us study, which is the largest study that the NIH has approached in this field. And All of Us has greater than 50% minorities on the patients that have been accrued to this trial. And there are over 300,000 individuals accrued already. And it is anticipated that at the 10-year end of accrual, we will have reached our goal of 1 million individuals. So with that, I'd like to thank the team again for allowing me to speak today and to be a part of the illustrious group of individuals who are a part of this program. So thank you very much, and I'm happy to answer questions.
I have to thank you so much, Dr. Edith Mitchell. And if we can bring her back onto the screen. First, again, biggest congratulations on your induction to the Royal College of Physicians. That was just a simply remarkable presentation. And it really echoes a lot of what we have touched on over the last few days. I particularly really enjoyed the fact that you look at the rear view. You mentioned the rear view and how important it is to look in the rear view in order for us to move forward. And I appreciate your mentioning the National Medical Association and the historical context and the importance of the NMA. And it encourages a young physician doc like me and hopefully others to be active in the NMA, but also the historical context of Jane Cook Wright, Dr. Jane Cook Wright, and the significance of that. We have a couple of questions, and I'm going to ask the first. The first is, what role has this data documenting breast cancer disparities played in terms of recommendations to healthcare institutions, cancer centers, and oncologists? Are we moving in a direction where the broader healthcare community is incorporating this data in the treatment of Black women with breast cancer?
Thank you so much for that question. And we do have some new ongoing things. It is recognized that the National Cancer Institute has on clinical trials approximately 9% African Americans across many disease sites. So Dr. Ned Sharpless, who is the director of the NCI, has recently announced a program on how institutions can increase the number of African American and other disparities on clinical trials. And he wants to know from our research what works, what doesn't work, but not only describe that, but to be able to incorporate that into the NCI clinical trials program. So you'll hear more about that. Also, we have studies that have evaluated breast cancer in populations. How do we get the patients onto the clinical trials? How do we enhance trust so that all communities can benefit from this new research? So those studies are ongoing, and I encourage everybody to participate in them. With the National Medical Association, we are a participant in the All of Us program. So sometimes you hear me talking about breast cancer or specific treatments, but other times you hear me speak about how can we get more individuals involved in All of Us so that we can look at some predictive factors, look at some research on prevention and the contribution of all of those factors on cancer initiation. What initiates this? There's also data showing that individuals during periods of stress have the production of factors that promote growth of cancers. So that's another area. We know that in many of our cities, as well as rural areas, that Blacks have more factors that contribute to stress. So is it the stress? We've got more obesity. How about the obesity in relationship to cancer cell initiation, cancer cell growth and the initiation of tumorigenesis? So there's a lot of research and all of us can contribute. So I think it's up to all of us to recruit students into medical school, and once in medical school, encourage them in fields of surgery, of radiation, of medical oncology, so that we've got more of us growing, and therefore we know that Black doctors and other minority physicians have a tendency to go back to our communities.
Absolutely. So that doctors
and do what you're doing this week.
Yes, ma'am.
A program.
Absolutely. Absolutely. I was trying to give you a break to take some water because you're on a roll there. So take your water. I'm going to ask you one more. Let's see. We have a great question. I actually was about to ask this question, and this is from a colleague of mine. And I'll sort of give a little preface to it. So I love when you said it is important that we not only address cancer equity, but cancer justice. And I think we have to really focus on the justice piece. How do we get there? Now, the attendees for tonight are very diverse in race, ethnicity, specialty. We have primary care physicians, we have cancer doctors, we have just people who are interested in narrowing the gap of breast disparities and cancer disparities. And so my question to you is, you have given such a great outline on ways to move forward with justice in clinical trials and community outreach and engagement. What would you recommend? And really, this is a question that we've asked many others who have presented. What would you recommend for, let's say, a primary care physician who is seeing a Black woman in their office? How should they approach this Black woman, and let's say they are of another race, because we want to give them the tools as well, right, to be an ally and join. How do they gain that trust? What mechanisms can they use to really help narrow the gap of disparities in this country? Mm-hmm.
So I think that every physician should know something about the individual patient, not just what their heart sounds like or the blood pressure is, but communicate with the patient. And if you communicate with the patient, you can find out a lot more about them and the factors in their life that could influence disease processes. So therefore, communicating and getting to know the patient. And with that, you can understand what drives the patient's information. You can do nutrition. And we know that we all say you are what you eat, and working with nutrition, but finding out those things in the community that community groups can do. And therefore, once you have the trust of the patient and you recommend something, they will usually do it. It is rare that a trusting patient will reject a recommendation. So it's not just having the patient come in, take a blood pressure, listen to the heart and so forth, and then they're out the door, but develop a relationship with the patient so that you know the patient is coming back. You know that the patient might not have insurance to cover mammograms or PAP or HPV testing for cervical cancer. And, you know, while we talk about breast cancer, the increase in cervical cancer, which is totally preventable, is increasing in the Black community, and that the CDC has a breast and cervical cancer screening program where if you apply for this funding, you can offer the patient a free mammogram and a free cervical cancer screening. So I think it's taking advantage of what needs the patients and communities have, and then utilizing our expertise in bringing in those necessary components, especially for or economically deprived communities. So if people haven't heard about the CDC program, find out about it. And if it is needed in your community, get that so that patients can undergo screening.
Dr. Mitchell, you are phenomenal as ever. And as Dr. Robert Wynn said earlier this week, trust and trustworthiness. So we have to be trustworthy. And as you outlined perfectly, you know, there are ways to gain that trustworthiness so that we have the trust of our patients. And with the hope that we will narrow that disparities gap. I want to thank you on behalf of our
And we got to straighten up that tree.
And we got to straighten up that tree. I hope to see you in Atlanta, Dr. Mitchell. Thank you so much.
Okay, take care and thank you so much.
Thank you so much.
Take care.